Now, it's been described by the opposition as putting ideology before people, but by the government as putting ownership and decision-making in the hands of professionals and patients. It's controversial. The Royal College of GPs, the Royal College of Nursing and the very influential King's Fund have all given it, I think, a lukewarm reception. GP-led consortia is also going to control up to 80% of the NHS budget. Instead of PCTs deciding on how money is spent on patient care in hospitals, it's going to be family doctors. Now, Ian Cumming, as Chief Executive of the outgoing NHS West Midlands, what's your view on what is really a radical shift of power? Do you believe it's going to liberate the NHS?
I think time will tell specifically on that answer, but I agree with you, it certainly is radical. This isn't a minor change in how we operate in the NHS. This is a very major change that does intend to put family doctors and other healthcare professionals at the heart of commissioning, as well as at the heart of providing NHS services. What we're seeing now, what we're trying to create now, is a situation where responsibility for patient care pathways rests with GPs, taking advice, support, information, help from colleagues in secondary and tertiary care, and looks at how best we can focus on the patient and the needs of the patient, and trying to perhaps move away more from organisational boundaries that have got in the way of seamless care in the past.
Dr. Andrew Coward, you've just heard what Ian Cumming has said. Are you rubbing your hands with glee at the prospect of taking over responsibility for these budgets, or are you worried about the kind of pace that's going to be required?
I think there's a balance there. I mean, as an example, our consortium will be responsible for £200 billion of public money, and in these particularly constrained times, that's going to be a huge challenge for us. I'd like to slightly contradict what Ian said. I do see it as more evolutionary. We've been subject to practice-based commissioning and world-class commissioning for the last few years, which I and other colleagues have been members of the so-called Clinical Management Board, which Moira Dummer initiated, and GPs have been used to taking strategic high-level decisions for a while. We're not rubbing our hands with glee at all. I think we approach it very soberly and very seriously, and are aware of the huge need we have to make sure that we spend this money in the most appropriate way for our citizens and our patients.
Now, Sue, as chair of a hospital trust, what is it going to mean to your organisation? Is it going to be better than dealing with PCTs, to deal with people like Andrew?
I think there were very good relationships between primary care trusts and acute hospitals, and that was certainly the case in our area, where we worked very collaboratively. I think there is a great worry amongst hospital trusts that some of the long-term strategic planning that has been happening with primary care trusts over recent years may either be put on hold or indeed be thrown into the air and start again, which is a great worry for those of us who've been working at that strategic level for some time.
Now, Jenny McCrorie, when you hear about all this change as a patient's representative, are you convinced that GPs can do a better job than the PCTs? Are you convinced that those relationships can be as productive as the ones that Sue was referring to?
I don't actually know. I think with my discussions with GPs, what I've actually found is a lot of them are very scared because they don't actually understand what's going on.
Scared of what? Scared
of having to take charge, I think. Scared of having to have a budget to make a choice of who gets what and who gets which treatment and who doesn't.
Is this something that you can identify with?
No, I wouldn't use the word scared. I think when you face something very serious and challenging, clearly you're going to be apprehensive about it. But I'm confident that with some of the high-quality managers that will be assigned to us, in our case from South Birmingham PCT, that we can rise to the challenge.
Now, I have a very wordy list here of all the things that world-class commissioning required. Now, GPs are trained as family doctors. What additional skills are consortia going to need to be able to perform all those skills as effectively as the PCTs did?
Well, I'm confident that those skills exist within very experienced local PCT staff. I am a GP. I'm not suddenly going to become a kind of wonderful manager overnight. That's not my role. My role within the consortium is to provide leadership.
Sue, do you think that GPs will learn quickly enough?
I think what worries me particularly is how far GPs will actually be talking to and listening to their patients. There are lay people sitting as non-executive directors on primary care trusts who are tasked with representing the views of patients. There's nothing in the legislation that requires GP consortia to have anybody with a sort of non-executive role. And acute trusts, like my own of course, have to talk to our patients. If we're foundation trusts, we have governors and members who are very vocal in talking to us. And I think there is a gap here about, you know, how will the patients be making their views known to the GPs?
Well, I think that of all the public sector servants, it's actually GPs who are closest to their communities. And I think the figures show that 98 or 99% of the entire population are registered with their GP. I'm not unusual in that I've lived and worked in Kings Norton for 20 years. I've known a lot of my patients longer than members of my family and even my closest friends. I've been spending 20 years listening to what my patients have been telling me about their experiences in the health service. Now we actually have an opportunity to start shaping some of that, because there's no doubt that we are in financially constrained times, and it's only right and proper and democratic that we involve our patients in how we spend that money, and we ask our patients how we can cut out some of the waste that inevitably is within primary and secondary care, I believe.
Ian, can I ask you, how do you think these new commissioning consortia are going to manage the many risks involved?
Well, I think, as we've already heard, this isn't about expecting highly skilled, highly trained doctors to take on roles that they haven't been trained to do. And in fact, being quite blunt, it's probably not a good use of their time to take on. So the expectation is that there will be a skilled workforce to support the doctors in their leadership role. One of the challenges, I think, in the new system is going to be making sure that we don't just focus on patients, that we actually focus on public, and particularly the public health agenda, the health improvement agenda, because as part of these changes, that function is transferring to local authorities. Now, my personal belief is actually that's the right thing to do, but I think there's going to be a real challenge to make sure that the benefits of having the health improvement function linked in to the commissioning function remain, because we need a health service that's more focused on predict and prevent in the future than perhaps on diagnose and treat. So it's not patients, it's public.
Now, Jenny, are patient groups like yours already being consulted enough, do you think, to ensure that your voices are being held by these new consortia? Is it happening?
I think if I gave you an example of what's happening in Shropshire, most GP practices have their own groups now, as already been discussed. But how they could be setting up their consortium, each consortium will have patients on their boards, and then all the way up to the board for the actual county, there'll be patients there. So every section will have patients with them. So, I mean, in Shropshire, I think we do quite well.
Now, Janesh Gupta, you're a very experienced surgeon and you're a professor of obstetrics and gynaecology at Birmingham Women's Hospital. Do you think that GPs understand enough about how hospital consultants like yourself deliver care to commission, to do it properly? I mean, are they aware, do you think, of the way it's done? Will they be able to replicate it?
I think we have had a very good relationship with GPs and the PCTs that that are going to be dissolved. And I think that system has worked very well. But I'm a little bit unsure as to how the widening number of consortia are going to actually have to be. The picture that's been painted has been very rosy about consortia taking over services and then be able to purchase these services from secondary care. But my concern a little bit is, we're going to have to then go and discuss it with a lot more consortia rather than a few PCTs, and convince them that we are the right people to deliver their patient services. And that's the bit that I'm not sure that the system has actually worked out carefully.
Well, can I put that to a practice manager, Vickie Baker? You're practice manager of a GP surgery in Solihull. How is your surgery gearing itself up for commissioning? Is this something that you're worried about, or do you feel prepared for the job?
It's a very daunting task. So I hope we're prepared for it. I think, as Andrew said earlier, we've been working towards it with practice-based commissioning, and we've been very active in Solihull. So we have a lot of new clinical pathways developed that we've been working closely with secondary care already to bring services and consultant-led services closer to patients out into primary care. I think the trouble that we have at grassroots level at the moment that is unclear is about the resource needed to implement the changes, and hopefully in the fullness of time there will be the structure that the panel have been talking about in terms of people who are skilled at management and commissioning to take on that role.
Dr. John Wilkinson, you're one of the GPs that work with Vickie in this GP surgery in Solihull. Are you considering retraining as an accountant to rise to the challenge?
Certainly not, and I'm not actually directly involved with the PBC and our consortia. One of my partners is, as I think we've actually done very well in Solihull. We've worked quite hard over the last couple of years. We've got 2 consortia who now work together very closely, and we've got good relationships with secondary care. And I think it's because we all talk to each other between ourselves and with secondary care that we have developed some very good innovations, bringing, as Vickie said, different services into the community, such as ENT and musculoskeletal services, things that in the past perhaps weren't so good for the patient and the patient journey.
I think for me, there's going to be lots of confusion. I use services myself. I've been using them for 45 years. Using the cystic fibrosis service, so I use both specialised services but also GP services. And I have to say I've got a very close relationship with GPs, even though I've changed practices over the years. And my biggest anxiety, and it is an anxiety and a tension, is this relationship in the near future. And I think there could be a major breakdown. We'll be dealing with external pressures, i.e. money. You know, you're going to have this £200 million to spend, this notional figure. I'm coming into your service in Kings Norton, and all of a sudden, things are getting a bit rocky. You're going to cut back some of my drugs, some of my services that I might want to access. And that's going to be a big tension for me in the future.
Can I put that question to Dr. Coward? I know it's not all the pressure's on you, but you spoke very confidently about the fact that you felt that the very strong relationship that you and your fellow GPs have with the community, with your patients, would mean that you'd put that almost at the heart of what you do, because that's what you've always done. But, Tom's very worried that actually that relationship will be eroded.
I can't see under any circumstances where a family doctor would like to stop or withdraw treatment that a patient, for example, with cystic fibrosis needs. That's not what this is about at all. GPs commission 80%, we purchase 80% of all NHS services. There has to be some control and restraint. Now, the control and restraint is with regard to waste. That is the issue. This is not at all about withdrawing or stopping treatments that patients need. It's about rationalising and doing things better.
Paul Vaughan, you're from the Royal College of Nurses for this region.
Yes.
What do you think when you hear these concerns, these worries being voiced?
There's a couple of things I'd say, and one of them is I think for GPs now it's going to become increasingly challenging for them because they are going to have to make some really tough decisions. We're seeing that already, and at the moment when decisions are being made around IVF, around new cancer drugs, who's making the decision? At the moment the government kind of takes a bit of a hit on that sometimes, and that responsibility is now firmly going to sit with GP consortia, GPs. So I do agree that there's a danger, the relationship between the public and the GP could potentially break down when some of those really tough decisions have to be made. Some of the concerns that we at the Royal College of Nursing would have is what provisions are going to be put in place to ensure that quality is really a core part of key performance indicators. Because cost is one of the things that we already know in the NHS is a real challenge. £20 billion has to come out of the NHS by 2014. Now, how in this huge period of change, when we're engaging, as you've said, in all of this, do we get that money out at a time when we're then saying, you know, we need to save money? How can we ensure that quality stays at the heart of what they're doing? Another huge challenge for GPs.
Can I put that to Ian Cumming? Yeah. Do you share those worries? Can you see how that might be a risk that's realistic?
Well, undoubtedly it's a risk. I agree with almost every word that's been spoken there. I suppose in response, I don't like the term any willing provider. It's any willing and qualified provider. And by qualified, I refer to the quality of care that's being delivered. I refer to an organisation that's staffed by appropriately trained and registered individuals, to an organisation that has got appropriate mechanisms in place to make sure that patient records are safe, etc., etc., etc. So it's not just somebody setting up on the high street saying, OK, we can do this now, come to us and we'll take NHS care. Now, those mechanisms are being worked on at the moment. I mean, it's very early days in terms of this transition. But in terms of the issues that need addressing, I agree with every one of them.
I'm hearing such a lot of gloom and doom, really, and all, oh dear, this is all so terrible. My question is, well, do we actually have a perfect system at the moment? And is that why we're so reluctant to leave it? Are GPs that much more likely to do badly than the present system? And I would say, why do we think that they're bound to? Because we seem to have this sudden presupposition that the present system's brilliant. And I would say that in terms of involvement of patients and the public, yes, there are statutory obligations, but do they happen? Do you feel, as a member of the public, that you are being involved by your PCT at the moment? And I think it's this, the intention is to bring commissioning to be more accessible to patients. This is a real opportunity for patients to get involved, you know, on the ground floor, because the whole exercise is moving to the ground floor. What I'm anxious about is, are GPs just going to be the fall guy? You know, are the PCTs running out the door at the time when things get really difficult?
I think we're going to leave close that discussion right there. I think we've got a case of really glass half empty, glass half full. Ladies and gentlemen, thank you very much.